Happy Monday, everybody. So today is going to be class 5, and we're going to talk about tissue healing and wound care. This is chapter 6 in the book that I showed you guys last time that we talked. So I'm going to go through. There are slides that go along with this, so I will reference the slides as we go through. This one is a little bit more extensive, but I think it holds a lot of detail that's very important for us, and so follow along. There is a notes sheet that goes with this for the assignment, and we will start right in. So slide 2, Intro to Tissue Healing and Wound Care. So this chapter, we're going to talk about general discussion of injury mechanisms, including descriptions of force and torque and the effects that they have on the human body. And then that's going to be followed by sections on soft tissue, bone, and nerve. So we're going to address the 3 different types of injuries or 3 different tissues that we can injure in the body. And then we're going to do a more detailed explanation of wound care for specific injuries. We'll go over those in different chapters throughout the quarter, getting more specific about how to care for certain injuries. In this, we're going to cover open versus closed wounds and how to care for those, but we're not going to go into a ton of detail about anything else yet. So slide 3, we're going to talk about factors that affect the likelihood of injury. Again, talking about force and torque, those are going to be where we are focusing. And so the size or the magnitude of the force is going to be a huge factor in the likelihood of injury. And then the direction in which the force is applied will also play a role in what kind of injury is occurring. The area over which the force is applied, that's going to be dependent on what kind of injury is occurring. The magnitude of stress produced by the force, and then we're going to look at the force's momentum arm, which determines the amount of torque that is generated. And then it also comes down to material properties of the tissues and what's affected and their ability to sustain themselves through that strain or that force. So on slide 4, we talk about force and its effects. So we're looking at when tissues sustain a force, 2 primary factors dictate whether injury will occur. Again, we just mentioned the size or magnitude of the force and then the material properties of the involved tissues. A load deformation curve demonstrates the deformation of a structure in response to progressive loading or the application of force. If a load is relatively small, the response of the structure is elastic, and as such, when the load is removed, the material will return to its original size and shape. Within the elastic region of the load deformation curve, the greater the stiffness of the material, the steeper the slope of the line becomes. Therefore, greater stiffness translates to less deformation in response to a given load. If a load exceeds the material's yield point or the elastic limit, however, the response of the structure is plastic. In this situation, when the load is removed from some amount of deformation will occur, or it will remain. So loads exceeding the ultimate failure point on the load deformation curve result in mechanical failure of the structure, which translates to fracturing of a bone or rupturing of soft tissues. When we're looking at axial force, force acting along the axis of a structure is termed axial force. When the opponent in fencing is touched with the foil is loaded axially, and when the human body is in an upright standing position, the body weight creates axial load on the femur and the tibia. Axial loading that produces a squeezing or crushing effect is termed compression force. So we're transferring into slide 5 now. We're going to start with compression. Oh, here we go. So the weight of the human body constantly produces compression, and compression on the bones that support the body. And so the 5th lumbar vertebrae must support the weight of the head, the trunk, and arms when the body is standing up straight, producing compression on the intervertebral discs down below it. When a football player is sandwiched between two opposing players, the force acting on that player is compressive. In the absence of sufficient padding, compressive forces often result in bruises or what we call contusions. Axial loading in the direction opposite of compression is called tensile force or tension. Tension is a pulling force that tends to stretch the object to which the force is applied. Muscle contraction produces tensile force on the attached bone, which enables movement of that bone. When the foot and ankle are inverted or rolled inside, the tensile force applied to the lateral or outside ligaments could result in an ankle sprain, and that would be tensile force that made the ankle sprain. Where compressive and tensile forces are directed respectively toward and away from an object, the third category of force is called shear force, and that acts as a parallel or tangent to a plane passing through the object. Shear force tends to cause one part of the object to slide or displace with respect to another part of the object. For example, shear forces acting on the spine can cause what's called a spondylolisthesis, a condition involving anterior slippage of the vertebrae. So if you're coming more like this in the vertebrae, involving that slippage of the vertebrae above or below it. When the human body sustains force, another important factor related to the likelihood of injury is the magnitude of stress produced by that force. Mechanical stress is defined as force divided by the surface area over which the force is applied. And then, hold on just a second. When a force is distributed over a large area, the resulting stress is less than if the force were distributed over a smaller area. Alternatively, if a force is concentrated over a small area, the mechanical stress is relatively high. A magnitude of stress rather than a high magnitude of force is what tends to result in injury to biologic tissues. And one of the reasons that participants in contact sports wear pads is because a pad dissipates force across the entire area and then reducing the stress acting upon the player. And then the last one on slide 5 is a strain. So strain may be thought of as the amount of deformation that an object undergoes in response to an applied force. So this is talking about strain in terms of force, not in terms of an injury. So we're going to talk about strains as an injury a little bit later in the slides. But here we're talking about application of compressive force to an object, which produces shortening and widening of the structure, whereas tensile force produces lengthening and narrowing of the structure. Shear results in internal changes in the structure on which the force is acting, and the ultimate strength of biologic tissues determine the amount of strain that a structure can withstand without fracturing or rupturing. So then we also have let's see here in slide. Sorry, we're still on slide. We're going to go into slide 6 and talk about acute injuries versus chronic injuries. So, injury to biological tissues or biologic tissues can result from a single traumatic force of relatively large magnitude, or it can result from repeated forces of relatively smaller magnitude. So when a single force produces an injury, the injury is called an acute injury, and the cause of that force is termed a macrotrauma. An acute injury such as a ruptured ACL in the knee or a fractured humerus up here in your arm, those would be deemed a macrotrauma. When repeated or chronic loading over a period of time produces an injury, that injury is called a chronic injury or a stress injury, and the cause mechanism is termed a microtrauma. A chronic injury such as bursitis or a stress fracture in the foot would develop and worsen gradually over time, typically culminating in an episode where the person can't take that stress anymore. Inflammation becomes very evident. Chronic injuries can persist for months or years. In slide 7, we're going to look at torque and the effects of torque, which is different than force. So 2 factors influence whether we're talking about in terms of like maybe a door. So we're talking about whether the door will swing in response to the force. So one factor is the force's magnitude, which we talked about before with the force as well. So now we're looking at the force's magnitude, and then is it going to torque or is it not going to torque? Equally important is also the force's moment arm, and so which is the perpendicular distance from the force's line of action to the axis of rotation. The product of a force and its moment arm is called torque. So that's where these things all come together. The torque may be thought of as a rotary force. It is the amount of torque acting on an object that will determine whether a rotating body, such as a door, will move. We're not going to cover too much more in torque right now. You guys should go through that a little bit more in a mechanical type class, mechanical physiology or something like that. So then we're going to move into slide 8, and now we're going to kick off and talk about soft tissue injuries. So here we're going to look at skin, tendon, muscle, and ligament injuries that are soft tissues that behave in characteristic ways when subjected to different forms of loading or force or torque. Anatomic structure and material composition influence the mechanical behavior of each tissue. So we're going to go through each of those and look at what that means for each tissue. I'm going to turn on the light, it's a little dark. That's a little better. All right, so slide 9. All right, so the major building block of skin, tendons, and ligaments is collagen, which is a protein that is strong in resisting force. Hold on just a moment. There we go. Collagen fibers have a wavy configuration in a tissue that is not under tension, and this enables collagenous tissues, which are inelastic, to stress a little bit when they're under tensile loading as the fibers straighten. Such as collagen fibers provide strength and flexibility to tissues, but they are relatively inelastic. Elastin, which is another protein substance, provides added elasticity to some of those connective tissues and structures. So the picture on that slide 9, shows you a little bit of the breakdown of what collagen versus elastin will look like, and the protein that gives these tissues elasticity. Slide 10, we begin talking about the skin. So the integumentary system is made up of the skin, the hair, the nails, and the glands of the skin, and this is the largest organ in the body. It provides protection and sensation, it regulates fluid balance and temperature, and it produces vitamins and immune system components. The skin is composed of 3 regions. We're talking about the outer region known as the epidermis, which has multiple layers containing the pigment melanin, along with the hair, nails, sebaceous glands, and sweat glands. The outer surface is made up of dead epithelial cells and is replaced every 3 to 4 weeks by new cells pushed up through the dermis. The dermis is the largest portion of the skin and provides both strength and structure. It contains blood vessels, nerve endings, hair follicles, sebaceous glands, and sweat glands, and is underneath the dermis. Let's see. And so on this page, there is, on that slide 10, there's a little breakdown of what the skin would look like. This is something you guys should have gone through in anatomy. If you want more of a breakdown, we can do that, but I was figuring you shouldn't need too much more into the skin. On slide 11, we're moving into tendons. Oh man, sorry. We're moving into tendons, aponeurosis, and muscles. So tendons are what connect muscle to bone, and they're composed of dense, regular connective tissue that consists of tightly packed bundles of unidirectional collagen fibers, and the collagen fibers are arranged in a parallel pattern, enabling resistance to high unidirectional tensile loads when the attached muscle contracts. The aponeuroses are another set of structures formed by dense, regular connective tissue, and these are strong, flat, sheet-like tissues that attach muscles to other muscles or to bones. And then we have muscle, which is a highly organized structure. It's a sheath known as the endomyosum, surrounds each muscle cell or fiber. Small numbers of fibers are bound up into fascicles by a dense connective tissue sheath called the perimyosum, and a muscle is composed of several fascicles surrounded by the epimyosum. And then we talk about how this muscle functions. So we're looking at viscoelasticity, extensibility, elasticity, and irritability. The structure and composition of muscle enable it to function in a viscoelastic fashion, and that is with both elasticity and time-dependent extensibility. So extensibility is the ability to be stretched or increase in length, whereas elasticity is the ability to return to normal length after either lengthening or shortening has taken place. The viscoelastic aspect of muscle extensibility enables muscle to stretch to greater lengths over time in response to a sustained tensile force. This means that a static stretch maintained for 30 seconds is more effective than a series of short ballistic stretches for increasing muscle length. Another of muscle's characteristic properties is irritability, and this is the ability to respond to a stimulus. Stimuli affecting muscles can be either electromechanical, such as an action potential from the acting or the attaching nerve, or can be mechanical, such as an external blow to the muscle. I'm sorry, that was electrochemical, not electromechanical. If the stimulus is of sufficient magnitude, like we talked about before, the muscle responds by developing tension, so it gets tighter. The ability to develop tension is a property that's unique only to muscles. Although some sources refer to this ability as contractility, a muscle may or may not shorten when tension is developed. So that depends on your varying levels of tightness in a muscle. Then we're moving into joint capsules and ligaments. And this is going to be starting on slide 12. So a joint capsule is a membrane that encloses a joint. It functions to hold the bones firmly in place. The outer portion of the capsule is fibrous and composed primarily of collagen. The inner lining of the capsule consists of a synovial membrane, which secretes a clear or slightly yellow liquid called synovial fluid, and that provides lubrication inside the articular capsule at synovial joints. And on the next slide, we're going to go through classification of joints. Here we're also talking about ligaments, and ligaments connect bone to bone. Similar to tendons, they are composed of dense, regular connective tissue that consists of tightly packed bundles of unidirectional collagen fibers. In ligaments, however, the parallel collagen fibers are also interwoven together. This arrangement is well suited to ligament function, providing resistance to large tensile loads along the long axis of the ligament, but it also provides resistance to smaller tensile loads from other directions. So this one acts in multi-directions, not just unidirectional. And then ligaments contain more elastin than tendons. And as such, they're somewhat more elastic. This is critical from a functional standpoint because ligaments are connected at both ends of bones, whereas tendons attach one end to muscle tissue, which has some elasticity. And then lastly on this slide, we're going to talk about a bursa. Bursa are membranous sacs that contain small amounts of synovial fluid, and they serve to reduce friction within a joint. Common sites for a bursa are the tissues where friction develops, including the area between tendons and bones, tendons and skin, and then ligaments and bone. So on this slide also there's a picture of a joint capsule there, and you should be able to see where a bursa comes in, where a ligament comes in. It's a little harder to see what the joint capsule looks like. Just think of it as like this sac that holds all of those things in place. Let's see, moving on into slide 13, talking about that classification of joints. Quite a few to go through right here. These should be somewhat familiar to you from anatomy or biology classes, but it's still important to go through. So first we're going to look at fibrous joints, and that's what we're going to deal mostly with. The fibrous joints of the bones are held together by fibrous tissue, and the amount of movement at a fibrous joint, or synarthrosis, depends on the length of the fibers that unite the bones. Hold on just a second. There we go. So a fibrous joint can absorb shock, but it permits little or no movement of the articulating bones. Within this, so the synarthrosis is the amount of movement at a fibrous joint. Fibrous joints can have sutures, which involve irregularly grooved articulating bone. Most commonly, this is seen in the skull. We can see when we look at a skull that there are suture lines of where those bones come together, and that's what we're talking about when we talk about sutures in a fibrous joint. And then syndesmosis are joints that are joined by dense fibrous tissues that permit extremely limited motion. So the tissue may be a ligament or a fibrous membrane, and then a unique part of that, or one of the unique ones, is the inferior tibiofibular joint, or the interosseous membrane between the radius and the ulna. So your ankle is one, and then your wrist is one as well. Then we're looking at cartilaginous joints. The cartilaginous joints unite bones by either hyaline cartilage or fibrocartilage. So the sternocostal joints and the epiphyseal plates before ossification are examples of primary cartilaginous joints. And so that's that definition there. This one's a tongue twister. Synchodrosis, which is articulating bones, are held together by a thin layer of hyaline cartilage. So that's what we see in the ribs. Our last joint that we're going to deal with, which is the most common that we're going to deal with as athletic trainers, are synovial joints. So from a functional perspective, synovial joints are the most common and most important type of joint. They normally provide free movement between the articulating bone surfaces. They are freely movable joints that predominantly are seen in limbs, whereas immovable and slightly movable joints largely are restricted to the axial skeleton. So we're going to look at what types of joints those are. A plane is the articulating surfaces are nearly flat, and the only movement permitted is non-axial gliding or short slipping movement. So we're looking at maybe the facet joints of the vertebrae. Next is a hinge joint. One articulating bone surface is concave and the other is convex. Strong collateral ligaments restrict motion to a single plane. Hinge joints permit flexion and extension only, and that can be seen at the elbow. A pivot joint comes next. It is a rounded end of one bone, rotates within a sleeve or ring composed of bone, allowing uniaxial rotation of one bone around its own long axis or against another. So if you're talking about the atlantoaxial joint in the back of your head, which allows rotation, and then both the proximal and distal radial ulnar joints are examples of this type of joint too. So if we're looking at up here in our elbow and allowing us, here we go, to rotate this way, that would be what we're looking at. Next is a condyloid. The oval articular surface of one bone fits into a reciprocal concavity of another. So an example of this would be the wrist joint here, and then your knuckle joints. A saddle joint. These biaxial joints resemble a condyloid joint. However, saddle joints allow greater freedom of movement. Each articular surface has both concave and convex areas, and it is shaped like a saddle. So the most common, or the easiest one to look at for this one, is your thumb joint, allowing you to move this way. Last is our ball and socket joint. The spherical or hemispherical head of one bone articulates with the cup-like socket of another, and these joints are multi-axial and the most freely moving synovial joints. They permit universal movement in all axes and planes, including rotation, and we see these in the hip and the shoulder joints. Moving on to slide 14, we're talking about the structure of synovial joints. The first thing that they have is articular cartilage. Glassy, smooth, hyaline cartilage covers the ends of the bony surfaces. These cushions absorb compression placed on the joint, and they protect the bone ends from being crushed. This cartilage has no nerves or blood vessels, and it is nourished by the synovial fluid covering its free surface. The joint or synovial cavity is unique to only synovial joints, and the joint cavity is filled with synovial fluid. The articular capsule. The joint cavity is enclosed by a double-layered capsule, and the external layer is a tough, flexible, fibrous capsule that is continuous with the periosteum of the articulating bones. And the capsule functions to help hold the bones of the joint in place. The inner layer is a synovial membrane composed of loose connective tissue, which covers all internal joint surfaces that are not hyaline cartilage. The synovial membrane produces synovial fluid that lubricates the joint. The fourth is synovial fluid, which is a small amount of fluid occupies all free space within a joint capsule. This fluid is derived largely from filtration from blood flowing through the capillaries in the synovial membrane. And then lastly, the structure of a synovial joint, we have reinforcing ligaments. Synovial joints are reinforced by a number of ligaments depending on the joint. More commonly, the ligaments are intrinsic or capsular. That is, they are thickened parts of the fibrous capsule. So in some cases, ligaments may remain distinct and are found outside the capsule, or they can be deep to the capsule, so extracapsular or intracapsular. All right, if you guys have any questions on synovial joints, please let me know. I did go over that pretty quickly, but it should be something that you've had in other courses. But in terms of injury, if there's something that you are curious about or you have more questions about, please let me know in an email or on campus. So we are moving on to slide 15, and we're going to look at the classification of skin injuries. So forces applied to the body in different ways and from different directions result in different types of injuries. And because the skin is the body's first layer of defense against injuries, it is the most commonly injured body tissue. So we're going to look at all the different kinds of injuries that can happen to tissue. First and foremost is an abrasion, which is a common scrape. It is a minor injury caused by shear when the skin is scraped with sufficient force, usually in one direction, against a rough surface. The greater the applied force, the more layers of skin are scraped away. So this could be anything from a rug burn to you fell on the street running and scraped your knee. That whole range is called an abrasion. Next are blisters, which are minor skin injuries caused by repeated application of shear in one or more directions. The most common is when a shoe rubs back and forth against the foot. The result is the formation of a pocket of fluid between the epidermis and the dermis as fluid migrates to the site of the injury. So it's just trying to get more fluid in to decrease the friction that's happening. Skin bruises we call contusions. Are injuries resulted from compression sustained during a blow. So damage to the underlying capillaries causes the accumulation of blood within the skin. And then we look at incisions, lacerations, avulsions, and punctures. They are breaks in the skin resulting from injury. So an incision is a clean cut produced by the application of a tensile force to the skin as it is stretched along a sharp edge. Usually those are surgical or purposeful, and they are straight line. There's no jag. There's no edges or like jagged edges to it. It's very clean. A laceration is an irregular tear in the skin that typically results from a combination of tension and shear. So those ones will have jagged edges. They'll be irregular, and that is what makes it different from an incision. An avulsion is a severe laceration that results in complete separation of the skin from the underlying tissue. And then a puncture wound results when a sharp cylindrical object penetrates the skin and the underlying tissue with tensile force. Moving to slide 16, the classification of muscle and tendon injuries. Injuries to soft tissues below the skin are also dependent on the nature of the causative force, the location of the force, and the material properties of the involved tissues. So here we're looking at muscle contusions or bruises, which result from direct compressive force sustained from a heavy blow. Those injuries vary in severity in accordance with the area and depth over which the blood vessels are ruptured. And then that's also what is in the table on that page for you guys, is classifying what kind of contusion or how severe the contusion is. Ecchymosis or tissue discoloration may be present if the hemorrhage is superficial. As blood and lymph flow into the damaged area, swelling will occur, often resulting in the formation of a hard mass, which is composed of blood and dead tissue cells, which would be called a hematoma. This mass, if left untreated, may restrict joint motion. And then we also have bursitis, which we talked about what a bursa is. Bursitis is what you develop if you have irritation of one or more of these bursa. Those can also be shown as swelling, and those can also be ruptured. All right, so then we're moving on to slide 17. We're going to start looking at specific types of tissue injuries, and we're going to start with a strain. So traumatic injury to muscles and tendons are called a strain, and they are caused by indirect forces which produce rupturing of the tissue and subsequently will cause a bruise or swelling around the area. The likelihood of strains depends on the magnitude of force and the structure's cross-sectional area. The greater the cross-sectional area of a muscle, the greater is the strength, meaning it can produce more force and translate that force to the attached tendon. Strains are categorized as first, second, or third degree, or we talk about them as first, second, or third, or a grade 1, grade 2, grade 3. A grade 1 or first degree strain involves only micro tearing of the collagen fibers. And then in the table on this slide as well, I mapped out what a first, second, and third degree strain looks like. Second degree injuries involve an extensive rupturing of the tissues and are characterized by moderate pain, muscle weakness, and loss of function. And then third degree injuries produce a major loss of tissue continuity, so that would be a complete rupture, and it results in significant loss of function or movement. Severe pain followed by decreased pain attributed to nerve separation is typical in a third degree strain. And then the tearing of muscle tissue can damage small blood vessels, which results in bleeding that may be present as swelling and ecchymosis, particularly if the damage is superficial rather than deep. So this all depends, and that table should help you be able to identify what a strain will look like. They look different in all types of muscles, big muscle groups, small muscle groups, and then from that first to third degree table. Next, moving on to slide 18 with tendinitis and tenosynovitis. They involve inflammation with the tendon itself or with the tendon sheath. Tendinitis is closely related to the process of normal aging and degenerative changes within the tendon, and it is characterized by pain and swelling with tendon movement. So this is fairly common, especially in repetitive athletes. Tenosynovitis may cause acute, or may be caused from an acute injury, or it can be chronic. Acute tenosynovitis is characterized by a grating sound, which is called crepitus, with movement. So it sounds, you can hear something moving in the tendon. And then they could also have local swelling. Chronic tenosynovitis has additional symptom of a little nodule that can form within the tendon sheath. So it might be something that you can actually feel. I skipped over tendinosis, which is a tendon condition associated with degeneration rather than inflammation. So that's something that you want to look at with your athlete. Is, are they going through something acute? Are they going through something chronic? Could this be degeneration, or is it just a typical inflammation of that tendon? On that slide also I have how you would be able to tell signs and symptoms of tendinitis. So look over those and read them, be familiar with them. I believe that is one of the questions that I have on your homework. Slide 19, we're moving on to, something else I wanted to talk about for strains. I just put it on here, something that would help you remember it. The T in strain is also the same as a T for tendon. Strains are caused in tendons and muscles, not in ligaments. So we move on to sprains, which is slide 19, and this is traumatic injury to ligaments. Again, sprains are classified or categorized as first, second, or third degree, or grade 1, grade 2, grade 3. They're caused by abnormally high tensile force that produce a stretching or tearing of tissues that compromises the ability of ligaments to stabilize the joint. So a first degree sprain involves only micro tearing of the collagen fibers. Second degree injuries involve tearing of nearly half the ligament fibers that result in a moderate loss of function and detectable joint instability. When we get into testing ligaments in each joint, we'll talk about what instability looks like in each joint and what ligaments we're testing and things like that. Third degree sprains produce a major loss of tissue continuity that result in a significant loss of function, severe instability, and severe pain. So if someone tears their ACL and we do a test on their knee, it will be pretty obvious. There will be much more movement. Again, this is why it's so important what we talked about last week in assessment, comparing the injured side to the healthy side, because then we'll be able to feel that degree of instability. So examples here of sprains would be an ACL tear, a UCL tear, or a high ankle sprain. And then next we are moving into the soft tissue healing process. So on slide 20, we're going to look at 3 phases of the process. The reparative process for injured soft tissue involves a complex series of interrelated physical and chemical activities that occur within the body. Because the normal healing process takes place in a regular and predictable fashion, knowledge of the various signs and symptoms exhibited at the injury site is essential for monitoring the process of healing. So more than likely, an injury is going to heal the same way for most people every time. Healing of soft tissue is a three-phase process involving inflammation, proliferation, and maturation. Although it is useful to discuss the healing phenomenon in terms of these different stages, you should also realize that these processes will usually overlap within different injured tissues. So something can be in the inflammatory phase, but also be started in the proliferation phase as well. And then the picture on the slide here is showing the process from bleeding into remodeling, or the maturation phase, and just showing how those tissues are healing throughout those processes or phases. So on slide 21, we are looking at the inflammatory phase. So the familiar symptoms of inflammation have been recognized for a long, long time and were documented by early Greek and Roman physicians. So those are those words that you see on the slide there. So we're looking at redness, local heat, so you'll be able to feel if a soft tissue injury is warm. There can be swelling, there will be pain, and there can potentially be loss of function. Depending on the nature of the causative forces, inflammation can be acute or chronic. Again, just looking at different ways that the person is injured. This does not only apply to open wounds. The inflammatory process applies to all kinds of injuries, open, closed, visual or not visual. This is a process that you may have gone through in biology. There's definitely a ton of science that goes into this, a lot of biology that goes into tissue building and what's happening during each phase. The things that I've listed on the slides are what I want you to know for this course. If you want more material for it, I definitely have it here in the book. But what's expected of you is what I talk about and what is in the slides. So we're going to look at three mechanisms that act to stop blood loss. So this is what happens in the first phase. So the first one, we're looking at vasoconstriction. And so we are wanting, the beginning of the acute inflammatory phase involves the activation of those three mechanisms. And the first one, like I said, is vasoconstriction, and that lasts from a few seconds to as long as 10 minutes. Larger blood vessels constrict in response to signals from your neurotransmitters, and then the capillaries and the smaller arterioles or venules constrict during injury. So the resulting reduction in the volume of blood flow in the region promotes increased blood viscosity or resistance to the flow, which further reduces blood loss at the injury site. The second response to the loss of blood is platelet reaction. And the platelet reaction provokes clotting as individual cells irreversibly combine with each other and with fibrin to form a mechanical plug that occludes the end of a ruptured blood vessel. And then the third response is the activation of the coagulation cascade. And the cascade is a heightened physiologic response consisting of several different interrelated processes. I just want you to know what the third phase is. You don't necessarily need to be as detailed about what's happening during it. Sorry, I got a little lost. We're moving on to slide 22, and we're looking at the proliferative phase. This begins on day 3. It can overlap with the inflammatory phase. It can last for up to 3 weeks. It involves repair and regeneration of the injured tissues. And then the proliferative process includes the development of new blood vessels, fibrous tissue formation and generation of new epithelial tissue, and wound concentration. So this stage begins when the size of the hematoma is sufficiently diminished to allow room for the growth of new tissue. Although the skin has the ability to regenerate new skin tissue, the other soft tissues replace damaged cells with scar tissue. Other characteristics of the proliferation phase include an increase in the number of blood vessels present, an increased water content in the injury zone, and then re-epithelialization at the surface caused by epithelial cells migrating from the periphery toward the center of the wound. And then we're looking on slide 23 at the maturation phase, which can last up to a year in some injuries. The final phase of soft tissue wound repair is called maturation, or also can be called remodeling. This period involves maturation of the newly formed tissue into scar tissue. The associated processes include decreased fibroblast activity, increased organization of the extracellular matrix, decreased tissue water content, reduced vascularity, and a return to normal histochemical activity. So in soft tissue, these processes begin approximately 3 weeks after injury occurs, and then overlaps with the proliferative phase in weeks 3 through 6. Because tendons and ligaments and muscles respond, they can get bigger or they can get smaller, hypertrophy or atrophy in the event of an injury, and so levels of mechanical force, complete immobilization of the injury will lead to atrophy, loss of strength, and decreased rate of healing in those tissues. So the amount of atrophy generally is proportional to the time of immobilization, and so when they're immobilized at the beginning of the at the beginning of the wound healing process, the strengthening exercises should be implemented as soon as appropriate during rehab to increase and promote wound healing. So now we're going to look at caring for some of these injuries. Like I said, today we're going to talk about open soft tissue injuries and then closed soft tissue injuries. And then when we go into specific joint injuries, we will look at how to care for those differently. But today we're just going to cover open and closed and the basics of how to manage those. So looking at slide 24, we're looking at open tissue injuries and the process of how to care for those. So first and foremost, no matter what, you always wash your hands before beginning treatment or touching an injury or the person. Wash your hands, put on gloves. Whether there's blood present or not, you want to be wearing gloves to protect you and to protect the injured person that you're talking with. You want to apply direct pressure to the wound with sterile gauze. This is if it's an open injury, there's going to be blood. So you want to apply direct pressure to the wound with gauze. Once the bleeding is stopped, you want to cleanse the wound and the area around the wound with saline water or a similar antiseptic. You want to appropriately dress and bandage the wound site securely for continued activity. If they are able to go back into competition and not bleed all over the place, that's completely appropriate as long as it is dressed and bandaged appropriately. And then closed, as long as blood is off the jersey, they're not bleeding anywhere that is like getting all over everything. They can go back to activity if appropriate. Creams or ointment may or may not be used with these kinds of dressings. It really depends on the kind of injury and what healing you're looking at happening. And then you want to change the dressings as necessary and look for signs of infection. Something that I tell athletes is that soap and water is the best thing that they can do. So when they're showering, just take off those bandages and then change it after that. Change it after athletic activity, after they sweat, after they've gotten dirty at any point. You want to be changing those bandages. They should not be seeping through at any point. And should be kept fairly clean and mostly dry. Slide 25, we're looking at closed soft tissue injuries. So these would be sprains, strains, fractures, anything like that. So you want to apply an ice pack for approximately 20 to 30 minutes directly to the skin and as quickly as possible. You want to elevate the body part at least 6 inches above the level of the heart just to offset that the blood flow and try to decrease that a little bit. You want to apply a compression wrap and continue elevation, and then you'll reapply ice for once an hour every 20 minutes, or sorry, every hour for 20 minutes. You don't want to go more than that because then you're just damaging more tissue than you're healing. For any suspected bone injuries, you would splint those and then send them off for emergency x-rays, send them to urgent care, things like that. We don't want to send someone home if we suspect a fracture. We want to get it looked at as soon as possible. And of course, they can't return to play until that has happened. Once we've taken care of acute management of these closed and open wounds, we would reassess the injury that has occurred, and we would facilitate first aid care, or not first aid care, we would facilitate more extensive care and referring them, that's the word, referring them to the team physician, to urgent care, or whatever they might need to get an x-ray, an MRI, have stitches. Any of those we would refer out after we have assessed the situation. All right, moving forward, now we're looking at bones. So on slide 26, we're talking about the anatomic properties of bone. Let me find my page really quick. So the primary constituents of bone are calcium carbonate, calcium phosphate, collagen, and water. Minerals make up 60 to 70% of your bone weight. And then longitudinal growth only occurs while the bone's epiphyseal plates or your growth plates are open. During or shortly after adolescence, those plates will disappear and the bones will fuse, terminating longitudinal growth. They won't get any longer at that point. So again, you guys will have had a lot of bone knowledge from anatomy or from biology, so go back and refresh that if you need to, but these are the main things that I want you to know for this course. On slide 27, we look at classification of bone injuries, and there are quite a few. So this picture that's listed on the slide, we're going to go left to right in each row from top to bottom of what these injuries look like, or what these fractures look like. So starting with the first one, a simple or closed fracture. So first of all, a fracture is a disruption of the continuity of the bone, just in general. It does not have a direction or anything like that. All of these can be classified as fractures. So signs of fracture include swelling and bruising or discoloration, deformity or shortening of the limb, point tenderness when you're palpating, grating or crepitus when moving, guarding or disability, and or exposed bone ends. So the type of fracture that is sustained depends on the type of mechanical loading that caused the incident, as well as the health and maturity of the bone at the time of injury. Fractures are considered to be closed when the bone end remains intact within the surrounding soft tissues, and to be open or compound when one bone or both bone ends protrude from the skin. Because bone is stronger in resisting compression than in resisting tension and shear, acute compression fractures of a bone are rare, but they do happen. Let's see here. So we'll go back to the slide and reference those a little bit better. So simple. This first one is closed. The bone breaks cleanly, but the ends do not break the skin. The second one is compound, which is open, and the bone ends penetrate through the soft tissue and the skin. The third one you can see on the skull occurs more frequently on flat bones when the broken portion is driven inward. The fourth one, a transverse fracture. The break occurs in a straight line across the bone, usually not open for those ones. A comminuted fracture is it will be the fifth one. It is bone fragments into several pieces when it is broken. The sixth one, an oblique fracture. The break occurs diagonally when torsion occurs at one end while the other is fixed. The seventh one, the epiphyseal fracture. Separation involves the epiphysis of the bone, so it's down at the bottom. It's a little hard to see on this slide, but it would be down in the growth plate, so happening only in adolescence. A spiral fracture. Jagged bone ends are S-shaped when excessive torsion is applied to a fixed bone. A green stick fracture, number 9. Bone breaks incompletely as like a healthy, if you take a stick off the ground and it was still alive, it would splinter rather than break all the way. That's why it's called a green stick fracture. And then the last one is impacted. A bone is impacted or driven into another piece of bone. So it could be either of the two on the bottom of that slide. Next, we're looking at acute management of bone injuries. So we talked about this a little bit, but not too much. So slide 28. These are the steps that you would take when suspecting a fracture of a bone. So possible fractures can be detected with palpation or percussion, which is the use of a tuning fork. That's the picture that we have on the slide right there. Excuse me. You can also use compression and distraction to detect a bone injury. And these tests we'll go through when we go through into specific joint injuries later on in the quarter. So a tuning fork or percussion uses a tapping motion of the finger over a bony structure. The tuning fork is the same. The vibration will travel through the bone and can cause increased pain at a fracture site. So that's what that little tool on the slide will show. So if you suspect a bone injury, these 12 steps are what you would do. So you want to remove any clothing or jewelry from around the site. You want to check distal pulse and sensations. You want to make sure that below the injury they can feel and have a pulse past that. If there's any decrease of those sensations or any decrease of pulse, you would activate EMS right away. You want to cover all wounds if the fracture is open. Even with a towel, it can help decrease the amount of shock, and it can help decrease the mayhem that can happen with people around if it can be seen. Number 4, do not attempt to push bone ends back under the skin if it's an open fracture. You want to pad a splint to prevent local pressure. Number 6, you want to apply minimal inline traction to maintain it until the splint is placed. This is really, it depends on what kind of fracture you have. This is something I don't normally do. I splint it how I find it, and then I send them to the urgent care or emergency room. When you are splinting, you immobilize the joints above and below the fracture site. Again, splint in the position that you found it. If pain increases with gentle traction or if the fracture is severely angulated, for me, I don't mess with it at all. If I think that it is fractured, I don't pull traction, I don't reposition, I just splint it as it is and I send them in to get it looked at. Number 9, do not straighten unless it's absolutely necessary. You want to splint firmly, but you don't want to impair circulation. So again, once you apply the splint, you want to check distal pulse and sensation. And then lastly, you check vital signs, you treat for shock, and then you transport them. Again, we'll go through more specific bone injuries when we go into joint specific throughout the quarter. Our last kind of injury that we're looking at are nerve injuries. And the nervous system is divided into the central nervous system, which contains the brain and the spinal cord, and then the peripheral nervous system, which includes 12 pairs of cranial nerves and 31 pairs of spinal nerves, along with their branches. The human body has 8 pairs of spinal nerves, which go from C1 to C8. There are 12 pairs of thoracic nerves, which go from T1 to T12. There's 5 pairs of lumbar nerves, which go from L1 to L5. 5 pairs of sacral nerves that go from S1 to S5. And 1 pair of tiny coccygeal nerves at the very bottom. Injuries to any of these nerves can be devastating to the individual and potentially resulting in temporary or permanent disability. So each spinal nerve is formed from anterior and posterior roots on the spinal cord that unite at the intervertebral foramen. The posterior branches are afferent or sensory nerves, and those are nerves that transmit information from sensory receptors in the skin, tendons, ligaments, and muscles to the central nervous system. The anterior branches are the efferent or motor nerves, and they transmit control signals to the muscles. And I'm sorry if I didn't specify, this was on slide 29. So on slide 30, we're looking at the classification of nerve injuries, and these can be caused by tensile force, and they are also graded in 3 levels. So the 3 levels are listed on the slide for you, and the picture can show a little bit of what's happening. So the first level is a localized conduction block that causes temporary loss of sensation and or motor function. This is the mildest form of nerve injury that you can have. Recovery for this kind usually occurs within days to a few weeks. Grade 2, those injuries will damage the axons of a nerve, and they are followed by complete degeneration of the peripheral segment without severance of the supporting structure of the nerve. These ones will tend to heal a little bit more slowly, about 1 to 2 millimeters a day. And then the grade 3 is complete severance of a nerve. More than likely, those nerves are not going to regenerate on their own. So those nerves will take either surgical repair or there is nothing else that can be done about it. So slide 3, we're talking about nerve healing and management. Complete severance of a nerve does not repair itself like I just talked about with a 3rd degree or grade 3 nerve injury. Most likely it will be permanent. Surgical repair is possible, and it can result in a neuroma, or which is a tumor that forms on the nerve. And then tensile injuries can heal if the surrounding myelin sheath remains intact. So it depends if that grade 2 or grade 3 threshold has been crossed. And then for any kind of nerve injury, regeneration is extremely slow, with a rate of less than 1 millimeter a day. But if you think about it, it could be 2.5 centimeters a month. We're not going to go too much into nerve injuries for this segment. So again, just knowing the 3 grades on what we're looking at, and then regeneration is of being extremely slow. All right, the last part that we're going to talk about is the neurologic basis of pain. So pain is a negative sensory and emotional experience associated with actual or potential tissue damage. So this is what the patient perceives that they are feeling. Perception of pain is influenced by various physical, chemical, social, and psychological factors. So the scale that I listed on here is usually what we will talk to an athlete about. Say, okay, on a scale of 0 to 10, tell me what your pain feels like. 0 is I feel great and I can go to everything. 10 is this is the worst pain I've ever felt and I need to go to the hospital right now. So we ask them to classify their pain on a scale for us if they can. So pain is caused by stimulation of specialized afferent nerve endings, which are called nociceptors, and those produce pain sensation. In most acute injuries, pain is initiated by mechanosensitive or sensitive to mechanical stimulation. Um, those nociceptors are responding to the traumatic force that caused the injury. In chronic injuries and then during the early stages of healing of those acute injuries, pain persists because of the activation of chemosensitive or sensitive to chemical stimulation, and those specific nociceptors. So to talk about this one, is gait control theory is a little more complex, so I added another YouTube video in here for you guys to go through and look at. It's a short 6-minute video to help explain that a little bit better. And then for one of the homework questions, I did want you to talk about gait control theory in your own words, just because it's one of the more important things for you to understand so that you can explain it to your patients when you're talking about this pain scale. So in terms of tissue healing, we have covered all of Chapter 6. I will upload the slides and the homework for you under Files on Canvas. And then I know we talked about possibly doing a Zoom or a Teams class. It is something that I'm looking into doing. I'm just not exactly positive how to do that yet. And get all of us in the same place. So I'm working with CIS to get my Zoom set up so that I can contact all of you at one time. Again, if you have questions, if you want more material, if you're having trouble with something, please don't hesitate to reach out. You all are doing great on your assignments so far, and I will get those to you by Friday, I believe is what I told you. Hoping for it to be earlier than that, and then I will see you all again on Wednesday.